Hey guys, welcome back for the second episode of the Mark Miller conversation. So we hope you enjoyed the first one. I know we did. It was really awesome to hear his history with Robin and how he kind of got exposed to MDT. And the second one, we get more into IMC and his role with that, how it began and how it kind of runs and how we can kind of incorporate some of the same principles with our practices that are maybe a little bit different. And so enjoy this conversation with Mark Miller. Okay, Mark, so there's no question that the current state of the healthcare in the United States is a disaster. We're spending more. We're basically the sickest country in the world, or, we're one of those. And
well, we keep saying that our healthcare system is the best, but that's an internal thing. But universally, we're not proving that out. That's true.
Yeah, so give us a current state of, let's just say, musculoskeletal health. What kind of burden does that have? And I mean, where are we at right now? Are we making a dent? Where are we at?
All right, so this could be a long conversation, and for those that had to sit through the first podcast, you know that I can get long-winded. but here's the deal: the World Health Organization in 2017 came out and they said low back pain. It was low back pain is the number one chronic disease problem in the world. So it's not just an American problem, right? It's not just a North American problem. It is a worldwide problem. I'm going to talk to this about in a second. 2018, they came back out in one of their bulletins and they said musculoskeletal is the number 2 chronic disability-based problem in the world. Now think about this. Are you kidding me? How is this happening? Okay, hold on. Chiropractors are becoming mainstream medicine, right? They're working in the hospitals and the VA. The literature is very clear as they continue to morph into a very scientifically based approach. Physical therapists, let's talk about them. They now get out of college and they're called doctors. And why? Because they now have this doctoral program. Physicians, primary care physicians, who, by the way, see 65% of all musculoskeletal. Now, 5 years ago, the data said it was 60. It's now gravitating more towards 70 because primary care is being asked to do more. So therefore, between 60 and 70% of all musculoskeletal starts at the primary care doctor's office, right? Primary care is now have a 3 to 4 year residency program after they get out of medical school. Everybody's advancing, right? Mm-hmm. We've got imaging that can pinpoint anything that's going on. You can get an MRI tomorrow and you'll see your grandmother's warts. I mean, that is pretty cool, right?
That got off the rails.
There you go.
Way to go weird, bro.
Yeah, that's amazing. Yeah.
Where's the wart, Mark?
Yeah. Where's it at?
I can tell you this, not only will it find your grandmother's warts, but I'll find you a surgeon that'll take it off and your back will feel better. How about that?
Well, I mean, the other thing too, Mark, not to interrupt you, but the one real important point, I think the author was in 2013, maybe Webster, on like the downstream cost of if you do an early MRI. Like, it's not the cost of the MRI because that's actually pretty cost effective at this point. It's what happens on the education of the MRI after that. Yeah.
So it's fine. Okay, you brought it up. It's a little early on. A lot of your viewers don't know. I am the president and the chief clinical officer for Integrated Musculoskeletal Care, which we affectionately call IMC. And our company's whole mission and value is we are a healthcare transformation company. And what we're trying to do is to get the best care to as many people as possible. That is our mission and vision, right? And so, but what's happened?
Cost effective, though.
Well, fair enough.
Okay.
Because what's happened to get to this point where we're actually now creating healthcare transformation in the area of musculoskeletal, you got to have data, right? In God you trust, but in everybody else bring data. Everybody knows that. So what we've done, and we've done it before. Okay, my partner's name is Chad Gray. He's the CEO of the company, and I met him on a McKenzie course. He was taking a Part D. I was told by Scott Hervally, you're going to meet a guy sharp as heck, inquisitive as hell, and he will not leave you alone till he gets his answers. And I'm teaching a Part D. He's above everybody in the class. His questions are like way beyond anything they'll probably ever think about in their lives. And I finally had to pull him off. I go, you can't ask me any more questions. You're done. I said, but what I'll do is I'll be glad to talk to you after the class. And he goes, okay, great. Can we go for dinner? I go, no. I'm out of town. I'm finally away. I got a 3-year-old and a 1-year-old, and I'm going to play golf. He goes, can I come with you? I said, done. You'll get your questions answered then. And we became fast friends. And that what happened was we both got talking about how bad musculoskeletal healthcare delivery is. Clinicians, every clinician has a different story. They never treat any patient the exact same way. There's no standardization. There's no quality assurance. You can have an MDT trained clinician who is a genius, and you can have an MDT trained clinician that you would send your worst enemy to, And it's like, so what do we do about it? How are we? And then that's within MDT, which is something we understand pretty well, and they're doing pretty good work compared to what we think everybody else is doing. And then so what happened was this: we started becoming friends, and we started looking at this, and then we started going, you know what, we got to fix this. We have got to fix healthcare delivery as it's applied to musculoskeletal. So then you go, well, how do you do that? Well, you got to start with an assessment process that at least has some level of intertester reliability, right? Now, granted, I must say I was biased. I was a McKenzie faculty, but if you remember back to the first podcast, I was going to quit musculoskeletal medicine. I was out because I just was so frustrated. MDT kind of brought me back in. Now, Chad, he was in the same situation. Here I got this guy in Tallahassee, Florida, who is realizing I picked wrong again. And then, of course, he took an MDT course, but Chad was a little more inquisitive and a little more intuitive. What he started doing was he started keeping outcomes on every one of his patients, which is not something that people did. But he wasn't doing it so that he could go out and market himself. He wasn't doing it so that he could go to parties and brag. What he was doing was he was going, all right, I got to try to change what I'm doing. I'm learning from these MDT courses, but I also got to apply, and then I got to go, all right, that's not working. Well, of course, I've been doing that myself. Now, I'd love to tell you that I was way ahead of everybody else. I knew that keeping data on patients was the way to go. No, all right? I'm on stage. I'm esponsing, right? I'm telling people the way they might want to think, but I didn't have a whole lot of scientific support. And so I started keeping outcomes on patients. I'll never forget this. I'm keeping outcomes. This is before Microsoft. This is before all that stuff, right? I'm keeping outcomes on patients. And I'm going, oh, that's working, that's not working. All right. And then I started, I'm going to do a McKenzie course like 2 weeks from now. So I would I draw these graphs on pieces of paper, and I go, this many people are getting better, this many people aren't, and this is what I'm doing to kind of fix the ones that aren't. And then I would take a photo, and I would take it down to a shop, and they would make me a slide of the photo, and then I would show that photo.
Oh God, you are old.
No kidding, dude. I'm telling you. And so that's how I was doing it. So Chad and I we were kindred spirits. We were, I was probably doing it a long time before he was, but we were doing the same thing. But we both recognized together that, you know what? The delivery system from a healthcare perspective for musculoskeletal is broken. And we know this stuff, and we've got data to support it. Maybe we should do something. Maybe we can do something. So that's how we became partners. That's how we started this thing. But we also knew there's no way as physical therapists, any of the incumbents, right? Incumbents don't like change, right? So there's no way the AMA, there's no way the American Academy of Family Physicians, the American College of Physicians, the American Academy of Orthopedic Surgeons, none of these guys, none of these women, none of these groups are going to allow us, even if we're right, they're not going to allow us to change anything unless we have data, right? So we started out figuring, you know what? We'll keep lots of data. We'll continue to standardize what we're doing. And because I was the guy that was doing the diploma program in Austin, and I had that kind of experience. Chad's like, you know what? I'm going to keep researching and trying to find places, not loopholes, but places where we can kind of insert what we're trying to do. And you keep trying to build out the standardization piece. I said, that's perfect. I do that anyway. So let me try to figure out how to standardize MDT trained clinicians. And you keep trying to figure out how to get us into the market. And together, you and I will keep moving this thing forward. So that's how it started.
What year was that?
That was around 2002, 2003.
Yeah.
Wow. So then in 2008, there was a breakthrough. What happened was Chad, and he can be pretty, if you ever get to meet him, he can be a pretty influential guy, right? So there was a local HMO in Tallahassee, Florida. Now, it's pretty cool because this never happens. But this HMO, they were a non-for-profit branch of Blue Cross Blue Shield. So Blue Cross Blue Shield says, you do what you want. They insured 70% of the whole catchment area, right? Wow. So the majority of people in Tallahassee and the greater Tallahassee area were insured by them. There was a chief clinical officer, and I can't remember his name right now, but Chad, being the kind of guy he is, goes in and says, hey, let me do this, and we can do that, and we've got data to support this, and da-da-da-da, and da-da-da-da, and the guy goes, thank you very much, I'll think about it. And then he says, 2 days later, go away, kid, you bugged me. And it's over. I'm teaching a course out in San Diego. I'll never forget this. And Chad and I went out a day early because we were friends and we were on this pathway together. And we were playing golf. His phone rings. And it's the chief medical officer for this HMO. And he says, I can't sleep. I'm thinking about what you said. And if you're right, everything we're doing is wrong. I'll tell you what, we'll give you a pilot study. So we did a pilot study with these people. And so they started sending all these patients to Chad, and his partner Tom Kane was the other guy. He owned the clinic. Chad, because of this deal, Chad and Tom became partners, and then they asked me if I'd be a partner. And so I was doing the quality assurance from Austin, Texas. These guys are in Tallahassee, and they're seeing patients and all of a sudden now there's 200 a month. There's no way they can do it. Did
you have a revenue stream for this pilot study, or you were just like,
no, just go for it, man.
Yeah, right.
But they did give them a premium on a fee for service basis, and to continue to do this. So I'm the quality assurance guy. I'm the guy on the phone, and yeah, what about that patient? What about that patient? What about this guy? What about you? What about that guy? What if and that doesn't work? And what if that works? So we're doing this, and finally Chad goes, you gotta give me some help, man. Right? So there's a couple guys that had done diploma with me, and I called them up and said, how do you want to be part of something that's going to change the world? And they're like, well, yeah, I'm in. So they moved to Tallahassee, Florida. And then that's how the whole thing kind of started, right? So think about this. You got an HMO. It has been ranked number 1 2 or 3 times in a row by NCQA, the rating agency for how good are you doing in healthcare. But they were in the 95th percentile in the nation for spine surgery, which is not a place you want to be if you're paying the bill.
Yep.
That's how we got in. Chad got us in. We got a pilot study within, I think it was within 2 years. It was the first glimpse we ever had of claims data, because no one shares claims data. And they didn't share it with us, but what they told us was this. We're now in the, I think it was 67th percentile. We do fewer surgeries, we do fewer injections, and we do fewer MRIs. We win, we're going to give you guys a long-term contract. So that's how the whole thing started. But it was all based on data, because we kept pen to paper data on every patient that went through, and it was really simple. By the 3rd visit, if they weren't steadily improving in the outcomes, we knew that what was going to happen is they were going to crash and burn, and we were doing something wrong. Either the diagnosis was wrong, the mechanical intervention was wrong, there was something psychosocially occurring that was getting in the way, or they didn't belong with us. They should have been referred on to somebody else. And so when we recognized this within the data, that's when we went, that's how you do quality assurance. You can actually do in real time quality assurance with clinicians if you have data points on every visit, and then if you know how to analyze the data. And that's where this whole idea of, yeah, you can create standards. And trust me, we have standards. We have 19 hours of online training for MDT trained clinicians, and we train them to a standard. But we recognize that they won't attain that standard or meet it consistently unless there's quality assurance that goes on every day. Now, quality assurance, you can do it anecdotally, you can do it subjectively, or you can use data. So what we did was we kept data on every patient, and we would, early on, we would just put it into Excel spreadsheets, and then I would look at it and look at it and look at it and go, there's the answer. Then over time, we started hiring consultants. Can you do this with computers? And yeah, they would, and they would put it in, and then they would do retrogression analysis. What ended up coming out of that was we built algorithms using now you'd call it AI actually, but we would just do regression analysis and go, if these data points aren't improving, these outcomes go south. And if these data points are doing well to a certain level by the third visit, these people do well. So what we decided was, let's just use these algorithms we've created in our database and go, if that spits out you and your patient every week, you bring these patients to what we call now grand rounds, and we'll have experts in the area to talk to you about that particular patient. And then if we do that, we should be able to guarantee an outcome. We should be able to know what's going to happen. So we kept analyzing that. We got it to a point that we were getting outcomes that we weren't seeing in the literature. And that's when we said, okay, now we got to figure out how to take this universally. And you know, we look. And then Chad would say the same thing. We would love to tell you we knew exactly what to do, and we got it to the right people. Oh my God, we got so close so many times, and then shut down. And then we got one really great break, and it was with Michelin Tire Company. And what happened was they were ready to change. It was about your question about musculoskeletal. Yeah. The thing was, musculoskeletal was killing them. It was their number one chronic problem. It was financially a problem within their healthcare system. So because musculoskeletal became so prevalent, and you got to remember, you're dealing with engineers here, right? These are people that measured performance by the microsecond. These are people that are building the best tires on the planet. Everything they do is so data-based. And yet, they're spending all this money on healthcare, musculoskeletal, their number one problem, and they've got all these people that don't even work for them who are sending them bills. In other words, you've got third-party purchasers that don't work for you. Doctors, physical therapists, chiropractors, hospitals, and they're spending your money, and you have no control over it. How do you think an engineering organization would feel about that? They got to a point where musculoskeletal was so out of control, they had to fix it.
The other thing, too, I think our listeners might not realize is how big of the piece of a pie chart MSK actually is. You hear cancer, you hear metabolic, you hear diabetes, but then, like, at the end of the day, when they look at the data in these companies, like MSK is a huge portion, way more than I think anybody probably realizes.
Yeah, so healthcare in general now eats up about 20% of the GDP, right? Which is crazy.
That's insane.
It's insanity. 4% of that. So think about it. 1/5 of that is musculoskeletal.
Wow.
Musculoskeletal has went from probably around the number 6, 7, 5 at best, 10, 15 years ago. It is now the number 3, 2, 1, depending on which company you're talking to, in terms of the medical issue that costs the most money. You think it's cancer, you think it's diabetes, you think it's heart disease. It's not. It's musculoskeletal. And so think about it. If you're the purchaser of musculoskeletal, now it's got your attention. Right? And what most people don't know is that 56% of all healthcare dollars are paid for by the self-insured industries of this country. So you may have a United Healthcare card, or you may have a Blue Cross Blue Shield card. It doesn't matter. They're just the TPA. They're just the third-party administrators who are signing the checks and paying the bill. For the guy who owns the bank account, 56% of all healthcare in this country is paid for by Ford Motor Company, by your city and state government, by Michelin Tire Company, by General Electric, by Apple, by Google. So do you not think that now that musculoskeletal is the number one spend and they're paying all the money, that they're not going to get involved. And that's when, and I got to give Chad a lot of credit here. He goes, you know what, Mark, because we were working with brokers and analysts and insurance companies, and we kept getting so close, and then they'd shut us down. Let's go to the self-insureds. And that was, Chad and I got talking about it, and he's like, I think this is the play.
Perfect segue to what I want to ask you.
Yeah.
So, in the TPAs, or like with the Blue Cross Blue Shield, let's say, can you explain why they, ironically, are not motivated by saving costs? Because I think that's actually like this crazy point, because I think all our listeners are going to think, well, Blue Cross Blue Shield would love somebody who's treating people less, but there's like this weird irony in that that's not actually the case. Can you?
Yeah, because the BUCAs, they call them, right? So you've got Blue Cross Blue Shield, and United Healthcare, and Aetna, and Cigna, and so you'd think, well, if you save them a bunch of money, they'd be very pleased, but that's not necessarily the truth, because they're bound by their government-driven contracts, right? The government says, hey, you're only allowed to make X. You got to spend so much money on administration, and you got to put so much money back into the healthcare system. You're only allowed to make 13%.
So this is so important for people to listen. This is like the biggest irony ever.
It's crazy. So no matter what happens, they just got to make 13%. So here's what happens. If they end up spending more and they only make 10% one year, they get to raise rates. Right? If they make 15%, they go, oh shit, we're making 15%. We got to spend 2 on something. And so they send it out and they do other things. So now, they make more and more and more money when they control certain aspects of healthcare, right? So, for instance, let's take Michelin Tire Company. This is a great one. So, Michelin Tire Company uses, they used to use United Healthcare. I think they're changing. But let's say when they were using United Healthcare. So, United Healthcare, they would be the TPA. They're just signing, they're just paying the bills, but they get paid for that. But then they go, oh, and by the way, Michelin, we'll build you a center of excellence. So they go in, they go to the different hospitals, they go to the surgeons, and they go, look, here's what happens. You got to decrease your infection rates, and it's not trying to kill too many people. And here's what happens. As long as you do it within a certain percentage, we can pay you this much money. And by the way, but you can't charge more than that. So then I can go back to Michelin, and I can tell them, this is what your surgeries are going to cost. And Michelin goes, well, you know what? Last year we spent $115,000, and this year we're going to spend $110,000, and we'll buy your program. Right? So this TPA, this United Healthcare, they're making it on both ends, because they're paying all the bills and they charge every time, and then they're building up these other little programs and products, and they get to make money on that. But if they insure the situation, they get to make 13%, and they don't give a shit if it goes up or down, because they get to change their fees based on it. Yeah, it's crazy, isn't it? It's absolutely nuts. So you would think the insurance companies would be behind a company like IMC, who goes in, fixes the patient, keeps the cost down, and fixes the patient by training the clinicians, monitoring the outcomes. When the outcomes aren't making it, has grand rounds every week, so the clinician is in a constant, never-ending learning curve. The patient gets the best care known to mankind, at least as best as that's not fair, at least the best that IMC can do, which so far our data shows that it's better than anything else.
Pretty good.
Or it's good. How about that? It's pretty good. It's as good as anything that's out there. And by the way, I'll tell you the story how we got the first contract, which is what we do now. But the bottom line is, the insurance company at the end of the day, they don't really care that much.
That is so, right? And I mean, that's going to surprise all our listeners.
Yeah, so it's kind of sad.
So then in your model, which I mean, no one really talks about, but I mean, I think this is like really turning the whole industry on its head, which is the potential provider is actually being rewarded for seeing the patient less times. What's happening now is, whether we want to admit it or not, you are actually financially rewarded by seeing a patient more times. Whether you're evidence-based or not, it's just a reality of the system. Right. So what you guys created was a case rate, which is basically, with the data that you guys collected, you're able to determine, like if I see this ICD-10 code, I know this case is worth this amount of money. So for once in all of our lives, you're actually being rewarded for less visits. So can you talk, I mean, how did you, this is so revolutionary. No one's giving you guys enough credit for how insane this is, because I think all of our listeners are in that, we're in that evidence-based circle, and we're trying to figure this all out, and we're all in our field, it's really ironic. I can't think of another field that is like this, where you're actually potentially penalized by doing a good ethical job, which is that's insane, right?
Yeah, it's insane, right? So Chad and I discussed this in depth over a lot of time, and we looked, and a lot of wine. So we looked at fee for service, right? We said, look, if we're going to provide this product, we're just going to charge a premium to fee for service. We're going to go in and go, hey, you pay us this much per unit, but you know what? We want double that. And for that, what you're going to get is we'll guarantee a clinical outcome. And not only that, because we know what's going to happen in the claims, we'll even guarantee you a savings, right? So that's where we're at now. But then the more we spend time on, we go, case rate's better, because case rate takes all the perversity out of the fee-for-service system. So if we're going to expand and develop, what we're going to have to do is we're going to have employees, but we're also going to have affiliates, and we're going to have a network of affiliates. And look, we're going to have affiliates we've never met. So how can we be sure? Right? How can we're quality assuring the clinical outcome, but how do we know they're not overbilling? How do we know they're not milking it a hair or two? And if they do, we look bad. It's not going to work. So we went to the organizations we were working with and said, look, I know this is kind of hard for you to understand. We want a case rate, and there's two reasons. A, we want to be paid for what we're doing, because we're not selling you chiropractic. We're not selling you physical therapy. We're selling you an outcome. You're buying an outcome. That's all you're buying. And how we get it, that's our business. Mm-hmm. However, we also are frustrated by the current system of fee-for-service, and we can't guarantee you that there's not going to be the odd guy that doesn't try to pad the system. So we're going to protect you by you paying us a service. Now, you're used to saying, well, at least if we pay fee for service, we know they spend a lot of time with patients. The more time someone's got to spend with a patient, the longer they're a patient. You don't want these people to be patients. You want these people to be tire producers. You let me take care of the outcome, which means they're a patient for the least amount of time humanly possible. And I guarantee you, when you let me take care of the patient piece, you got tire producers. You got to trust us on this. And they went for it. And they said, okay, you know what? We're going to do this. If you can guarantee us that you will get an outcome, and you can guarantee us that you will save us X amount of dollars, I'll give you a case rate. And that's how it started.
And then for Michelin, Mark, how were you able to control steerage? Obviously, people have their right to go see their chiro, their PT, their massage therapist, whatever it might be. How were you able to make these people funnel into your system? What was the incentive?
All right, so as you well know, there are carrots and there are sticks, right? And so our advice was, why don't you give them some carrots, right? Give them a little more money so they come to see us, or figure something out. Give them a day off. Hey, go see IMC, take a day off. You know what? Here's some flowers for your husband. But the point is, give them something that's positive. No, we're not going to do that. So the other way you can do that is you can stop the MRI in non-emergent environments. You can say no to surgery unless you've seen an IMC clinician. That's the path they took. And you know what, by the way, it works. You were saying something about, we know that the downstream cost, once a guy has an MRI, it's pretty excessive. Here's what it is. We have done, not only with Michelin, but we have done this data collection, data analytics of billions of dollars of musculoskeletal care. And what we found is this: if you have an MRI, the cost is 4 times than if you don't. That's just the data. That's what happens. So our point to Michelin was, get us out in front of the MRI and we'll fix people and we'll save you money. Let them have an MRI and now we got a problem. And so what they did was they created a stick. You can have an MRI, but you got to pay for it. But if you go through these guys first, we'll pay for everything. So that's what they did. It was like a carrot stick thing. So the only way really that we found thus far that creates the kind of steerage that you're talking about, so that we can make an impact not only from a clinical perspective but also from an economic, is there has to be something built in to the plan design that gets out in front of a patient getting an MRI. They can have a surgical consult, though we prefer they didn't. They can have one, but they can't have an MRI. Because
So
once
for
that
our
MRI
listeners, to Mark's point, just so you know the money we're talking about, that study that we were talking about, Webster in 2013, it basically, the average cost of that case was $13,000. Like if you did that MRI. So, I mean, that number, to me, it just sounds so staggering.
For an MRI that could probably cost cash rate $500.
Okay, so take 500
You know,
off the
but I mean,
table.
that's
right.
insane.
Because
So how do you explain the 12,500 then at that, you know?
How does that drive care, right? Because we know that MRIs are not sensitive. We know that it can pick up your grandmother's warts. And we know that conservative care is not overly successful, right?
Well, yeah, after.
Right. So no, even before. So think about this. Just go to the wild. Just go to the general wild. Here's what happens. 60 to 65 to 70% of all musculoskeletal starts at the primary care office, right? They have very limited training in how to examine and treat musculoskeletal. And they'll admit it if you sit down with them and have a drink with them, and they'll go, well, you know what? Now that you're saying it, nobody taught me anything. I kind of learn as I go, right? So I'm telling you, half the medical schools in this country, guess what? 2 weeks of musculoskeletal. It's 30% of their day. They get 2 weeks. Half the medical schools, the other half, they get nothing. By the way, the groups that get 2 weeks, it's an elective, right? Right now, IMC is the preceptor for the musculoskeletal program for TMH's their primary care residency program. Do you know how long it has taken for us to finally get into that spot? And what we're hearing from the residents is, yeah, this is great because we're getting a lot more musculoskeletal. And when I tell them, do you know that when you get out of here, a third of your day is going to be musculoskeletal? And they go, I didn't know that. And I go, are you pretty good at diabetes? Yep. How's heart disease? Excellent. How do you do with just general population health? I think I'm pretty prepared. How do you feel about musculoskeletal? Don't know a thing. And then you think about it and you go, wow, but they're the decision makers. And what do? If they don't know, they boot it. They boot it to x-ray, they boot it to some medications, and if the problem doesn't go away on its own, they might boot it to chiropractic, they might boot it to physical therapy. But we all know
it's a shot in the dark.
Yeah, and because physical therapy is a profession. Chiropractic, it's a profession. It's not a process or a way of doing things.
Or procedure.
There's no standardization whatsoever. So if you're a family doctor and you kick it into conservative care, you don't know what you're getting. All someone has to do is fail for a couple of weeks. Now they get an image. Once that MRI is in place, it can't be ignored. Whatever that thing shows, and we all know the false positives are incredible. Once it shows it, an orthopedic surgeon, how can you blame them? They failed conservative management. This is my training. It's right in front of me. I'm doing something with it. That's why it's 12, 13,000. But we all know, though, from an MDT perspective, and I can only vouch for this because it's the only thing that I do, is that 92% of these are mechanical. And actually, if you know what you're doing, or if you continue to build your skill set, you can figure it out.
You're not Nostradamus, but if you're making a prediction, so in saying everything that we just said, 10 years from now, would a TPA ever embrace a case rate? Or is that just like so far off that like we shouldn't even talk about? I mean, like, in your honest opinion, I mean, is it...
So
is that possible in our lifetime or not?
Absolutely. So, or not.
Yes, or no.
You asked the wrong guy.
Like a weatherman.
Mark Miller, weatherman. So when my wife and family and
man.
Yeah, that's right.
Inside joke later.
No, later. You explain it to him.
Yeah.
Don't involve me. But you can reference me, but don't involve me. So when my wife and I and my children, we moved to Tallahassee, Florida, we signed a 3-year deal with Chad. Because when you think about it, if you've got data and you're on the right track, how long can it take to change healthcare? Well, here I am. Still working at it. So you're now asking me a question about...
Well, you still have a partner. That's
it's a very good point.
Yeah.
It's a very good point. So do I see case rates being the methodology in the future? And the answer is yes. And our organization is doing everything we can to do it. Yes, I think you're going to see it in your lifetime, but you're only going to see it for that group that will, be doing something that's different, because what's being done isn't working. Musculoskeletal is now the number 2 chronic problem in the world. So if it's not new, it ain't happening. It has to be scientifically supported, which means there must be enough science behind it to make it reasonable. 3, there must be patient-based evidence. There's got to be enough patient-based evidence to take what the science says might have an opportunity to make it generalizable. 4, it's got to be scalable. You can't go into somebody and go, hey, I got really something great, but I can only do it here in St. Louis. Case rates? Are you kidding me? They're not going to buy it. And 5, it must be good enough that the clinician that's supplying it is willing to go at risk. But if you're willing to go at risk, they're willing to pay. If you're willing to say, you know what, I'm telling you, I'll contract this with you. I will contract to you that I will get these clinical outcomes on scientific-based metrics. I'll do it for you, which is one of the things our organization does. And I'll guarantee you that we'll show you these every quarter. And if they drop down, I'll pay you back. Oh, and by the way, what I'll also do is this. At the end of the year, you take every patient we saw and you match pair it with those that we're seeing in the community. And I'll guarantee you that it is going to be this much cheaper. I'll give you this %. And if it's not, whatever I didn't create, I'll pay you back. Which means we know we can do it, and we know we'll provide it. And by the way, you have no risk. I'll take all the risk. I'll take it. And when you can do that, you can get all the case rates you want. But that's, and by the way, to your listeners, don't feel the pressure of having to be able to do that. That's not fair. But our organization's been able to do it.
Mark, in the most ultimate push your chips all in moment of your life with Michelin, can you tell our listeners what you basically guaranteed? And I mean, how that probably closed the deal, I would imagine, right? And then at that moment, you had to just been like,
I got to
reevaluating everything at that point.
As long as you promise me that my wife will never hear this podcast, I will tell you this story. This is a true story. So we've gone up to Michelin a couple of times, all right? And let's face it, it was a little bit intimidating. I'd love to tell you that we went in confident. Wait till they get a load of us. It's like, oh my God, they're talking to us. And so
they're listening.
Yeah, that's right. But here's what we do. We knew that musculoskeletal was on their mind, and we knew that they were looking for an answer. But our problem was, we were just a small little organization, and we were really just sort of getting started, and we didn't have that much data. And the only actual financial data that we had was that little thing from that capital health plan story I told you. Okay. We didn't even have the dollar amount. What we had to do was take the fact that they went from number 95 to 67, and we had to extrapolate, and they had to look at and we figured out maybe what the cost might be, right? So that's what Chad and I had. And we went to them a couple of times, and they were obviously interested. So I'll never forget this. I'll never forget it as long as I live. So we had our clinic in Tallahassee, and it's doing very well. We're local guys, and we're at least at that level, that's going well. So we had this boardroom, right? And we had the big speakerphone in the middle. It was like the Jerry Maguire thing, right? And we're on the phone with this fella, and I won't say his name because it's not fair. But anyway, he is the purchaser for Michelin. This is a guy, think about this. He's buying, and I can't tell you the dollar amount, so I'll make one up. But it's kind of close. How about not $1 billion, but not $1 million? Now I'll just leave it at that.
Yeah.
All right? He purchases that much healthcare every year for this company. He's the negotiator, right? So that's the guy we got on the phone. And we've been with him like 4 or 5 times, right? So we're in this meeting, and we know, Chad and I know, we can smell it. The contract's going to happen, right? And the phone's on, and Chad and I are walking around the table, and we're nervous, and we're excited, and we're frustrated. And this guy's nailing us. He's nickel and diming the living heck out of us, right? Finally, Chad goes, "Holy crow! Mike, okay, those weren't the exact words. And he goes, we're going to save you 40% on your healthcare dollar, and you are killing us. And I look over at Chad and I go, 40%? What the hell are you doing? And I'm mouthing it, right? And he goes, and he shrugs his shoulder, and he's like, I don't know, right? And there's silence. And the guy goes, 40%? You're going to save us 40%. Chad's looking at me, and I'm looking at him, and we're like, oh. Chad goes, yeah, we're going to save you 40%. He goes, he'll put it in a contract. We're looking at each other, and yeah, we'll do it. He goes, fine, I'll send the contract over. Click, right? We click the phone off. We jump into each other's arms. We're hugging each other. We're like, we got the contract, man. We got the contract. And then we separate. We go, oh my God.
What did we do?
Oh my God. We got the contract. We never told anyone. We never told a soul. We signed the contract. And we killed it. 56%.
Let's go.
You know it, baby. 56% the first year. 6 months into the contract, they called us up and said, we want to do a long term. It was like, that was it. And you know what? We kind of knew we could. We had all the quality assurance and the standardization pieces in place. Though, by the way, at that time, we didn't have it so data enabled that it was perfect. We didn't have it running through databases and coming back. We didn't have all that science, but we had spreadsheets. We kept outcomes on everybody. Like, oh, that guy's not doing good. All right, Miller, get in there. But we did it, and it's so funny looking back now, because at the time, it was fairly traumatic. But the next day we got over it, and it's like, hey, let's get on with it, man. We got stuff to do. And we didn't tell our wives.
Good choice. We'll edit that out.
No. And that's it, So that's how it happened. But the cool thing is, it happened. And we were able to do it. And so what was happening was we were recognizing that our standardization, maybe not, but at least our quality assurance or something, between the two of them, it was working. We could actually get better clinical outcomes than currently was happening in the wild, and it was saving money. See, think about this. We all think we're good. Clinicians, they have to think they're doing a great job. Otherwise, how can you go to work every day? You can't do it. You don't know till you measure. And then once you start to measure, you got to go, all right, I can accept this. How do I improve? But that's what we've built. Because the only way to change musculoskeletal healthcare delivery is to ensure that A, it's a better product, B, it gets them better, C, they stay better, and D, you can scale it. So
in E, you save money. I mean, I think the thing that is really, you never really see this in the business world. In your model right now, what you're proposing is you are actually decreasing cost, but you're increasing value.
That's correct.
You really don't see that. I mean,
no.
Usually, if you're going to decrease cost, you're going to
cut
substitute value on something.
Right.
But this is the perfect storm of
that's
economics or whatever.
Well, no. If you think about it, think about it came out of Harvard Business School. It was a guy named Michael Porter, and he came up with the healthcare value equation. And what it was outcome divided by cost. Look, if the cost is too much, you can't pay for the outcome. But if you don't get the outcome, no matter how little it costs, it's irrelevant. Right? Think about this. Here's a novel idea. Fix the person. And it costs less money. It's amazing. It's phenomenal when you think about it. The problem is, the way the current payment system is,
don't fix
them, you make more money. It's nuts. So you know what? You want to change healthcare? Go to the guy that's paying the bill. And when he pays it, it hurts him. He'll help you. And that's what we did. But before you can do that, you have to have a process that actually resolves the condition. And not only resolves it, because we didn't just look at cost, we looked at downstream cost. In other words, we own that patient for a year. And you got to remember, the deal we made was, it's not what you pay us. It's what you pay everybody for that person for 1 year after we're done. You better make sure you know what you're doing before you make that promise, right? So how did we know? We knew because we had enough information from the pilot study we did with that original little thing that Chad put together in Tallahassee, Florida. And we were hoping that we could universalize it. And we were able to do it. And now that's what our company is. And that's what we do. And so your question is, what do I see in terms of case rates? Well, as long as we can continue to grow and develop, and all the market spoilers who are trying to jump into this musculoskeletal world because everybody wants an answer now. So there's a lot of money. And what you're seeing is venture capital money is diving into this right now. So anybody who's got a technological approach, they're getting millions and millions of dollars. And so then if I'm your listener, I go, well, why has an IMC taken on venture money? Because they're going to want to return in 3 years. And I learned 13 years ago, it takes more than 3 years, right? So if we let venture in and they want to control, then healthcare transformation doesn't happen. Just people make a lot of money. Healthcare transformation is necessary. Why? Because low back pain is the #1 chronic problem in the world, and musculoskeletal is the #2. And if you have the key to the door and you don't open it up, there's a place that you'll end up in. The bottom line is this. We have a responsibility. You have a responsibility. You guys know what I'm talking about. You guys know what we're doing. We all have a responsibility because we have an answer. So now the question is, how do we get it out there? And the incumbents don't want it. The big payers really don't care. So what do? You go to the people that care the most. And what we found is the self-insured employers of this country, they now care. And they're interested in changing healthcare. So as long as you can A, show them something different, B, show them that the science agrees, C, show them that you've got patient-based evidence that allows you to generalize it, D, shows them that they can save money doing it, and the last one, can you scale it so that you can cover their whole population? And when you can do those things, they're going to help you. And that's where we're at now. It's kind of cool.
Mark, in the timeline of everything we've just talked about, I remember when I was young, I read Ronald Donaldson's book on rapidly reversing.
Yeah.
So where did that fit in? Did that motivate you, or did that book come after? Your thoughts? How would you describe?
Okay, well, I'd love to tell you that Ron and I kind of got on the scene around the same time, right? But he was an orthopedic surgeon, I was a physical therapist. So there's a totem pole, right? So I always make this joke.
Don't talk to chiropractors about totem pole. So, we're here, you're here.
No, so I'm with patients, right? They'll go, hey, can you get me an MRI? And I go, do you know who I am? I go, here's the way this works. There's your orthopedic and neurosurgeons, and then there's your specialists, and then there's your primary care physicians, and then your PAs and nurse practitioners, and then there's your there's us, there's your physical therapist, and then there's the janitor. I tell you what, I can't get you an MRI, but I can get your floor washed. I can make a phone call right now, man. I can make that happen. Right? So when I meet Ron Donaldson, right? Ron is like, whoa, he's MDT, like he's the golden child, right? Because he just published a centralization paper in I think it was 1987 that showed that centralization is something that can help you predict outcomes and stuff. And so when I met him, I was really excited. And then him and I got talking a couple of times, a little bit, and this was after I trained with Robin, and he says, how'd you like to move to Syracuse? That's how I got into America. I said, well, what are you doing there? He goes, we're gonna research acute back pain, and I said, I'm in. I'll summer practice. I'm coming. So so I know Ron very, very well. He's a great guy, and actually, Ron published the first. Kevin Spratt was the lead author. Ron was the second author. I think it was vice versa. But I don't know if you've read the paper where we were able to show that using an MDT trained clinician who was standardized and quality assured, when you compared their financial impact on low back pain to the wild, you were able to decrease low back pain costs by 56%. That's Ron's paper. So Ron and I have been friends since 1992, 93, but he's worked with IMC in a number of different ways. He has a researcher. He's helped us with a number of different concepts and ideas, and So Ron.
Well, to me, in his book, like he kind of exposes some stuff. You guys were the implementers. Would you agree or no?
I would agree with that. Yeah.
Okay, that's fair.
I would agree with that for sure. And again, Ron's book, we still use it for support on the scientific side. When you look at the big five that I've described a couple of times, Ron's work helps us on the science side, because you got to have science behind something, or you're not going to be able to get people to feel comfortable with what you're introducing. You got to remember, we're walking into these organizations and we're saying, we'd like to change just everything you're doing.
And when you read the title of Ron's book, I remember when I was a student thinking I'm like going to dive into this mechanical book, and it actually ended up being a book about the payer system and kind of exposing the problem. It's kind of like a really interesting. No one knows about this book. Nobody. It's like you talk about a book that just flew under the radar.
It's insane.
Yeah,
it makes no sense. Ron has tried many times around a number of different ventures to try to get the physicians of the world to start paying attention to this, so they'll change the way they train in terms of musculoskeletal. And you know what? I know him, and he'll do it. I'm telling you, his last breath will be, you gotta change, you gotta fix it, you gotta try harder, and he's all about the science. His book is, I think his book is great.
He was a good man.
Oh, we love that guy. Yep. But he's still working at it. He's still trying. He's got it. He actually has a couple of codcasts. That would be the wine talking about fishing on the East Coast. But he also has a couple of podcasts. Right? And those podcasts are around teaching primary care to better understand what the science is saying about what you should do with low back pain. So he hasn't stopped. He's still going.
Mm-hmm. I love it. Awesome. Well, what a whirlwind of 2 podcast episodes that we've gone down, Mark. Thank you so much for not only inspiring us to collect data, to pay attention to your patients, to stay inspired. We're so lucky to be able to sit down with guests like Mark, and I'm so invigorated and inspired to keep pushing forward in my clinical practice in the profession, and to really improve musculoskeletal care in general. And so you've kind of laid the outcomes for us and the groundwork. And so thank you again. We owe you more wine. That's for dang sure. So
no, it's been my pleasure. And look, if something comes up to the podcast and we create change, whether it's local or whether it's statewide or national, I'll do it all day long.
Where can people find more about IMC?
They can just hit the website.
Beautiful.
Yep. IMC, I think it's imcpt.com.
Beautiful. Awesome, guys. Well, thank you for tuning in, and man, what a cool episode. So keep crushing patients on Monday, and we'll be back for more.